Good evening, everyone. My name is Dr. J Lakhani, and I've been asked to talk on guidelines for management of postmenopausal osteoporosis. But I'm going to go one step further, and I'm going to talk to you about step-by-step management of osteoporosis in postmenopausal women. We'll try to make things simple, right? And we are going to use both the guidelines as well as some personal expert recommendations, right? So that is what we are going to do in the next few minutes regarding the management of postmenopausal osteoporosis. So if you are a endocrinologist, if you're a physician, if you're an orthopedic surgeon, if you're a gynecologist, this is a very, very useful video for you to really watch, or a rheumatologist, right? It will be useful for you in your practice. Okay, so let's talk about step-by-step management of osteoporosis in postmenopausal women. Now, let's look at the first step in assessment of that, right? So the first step is to do some essential things. Now, when you have a patient with osteoporosis, obviously you need to measure the BMD and DEXA. BMD, DEXA, I'm sure the people who are listening to this are well aware about the diagnostic criteria for osteoporosis. Secondly, you need to calculate the FRAX score. I'll talk to you about how to do that. There are some very basic tests that you have to do in all patients with osteoporosis before you begin the assessment. And there are some clinical assessments which you need to do when you are assessing a patient with osteoporosis. So let's look at the FRAX score. Now, BMD DEXA, like I said, you will be doing it in your center, depending on the machine you're using. But when you have the BMD result, with or without BMD result, you can calculate the FRAX score. The FRAX score is available easily on the University of Sheffield website. You can Google it and search it. You need to know what FRAX score you are calculating for what country. So if you are from India, there is a FRAX score available for India. Many countries have their own individual FRAX score available, so you can check the Sheffield database for that. Currently, you can see here it says India, so this is the data we are going to use. The FRAX score uses a certain set of questionnaire which you need to fill up. You can see the questionnaire again easily from Google, so it's very easy to calculate. Now, the femoral neck bone mineral density is required, but that is elective, so you can calculate FRAX without adding the femoral neck BMD also. However, it is always better to include the femoral neck BMD if you have the data available for the same. So you need to calculate the FRAX score. That's the first step in assessment of a patient with BMD. Now, there are certain basic tests you have to do in all patients before you assess and treat patients with osteoporosis. So a very basic test, you need to calculate you need to see the calcium of the patient, vitamin D, parathyroid, alkaline phosphatase, and serum creatinine value. So this must be done in all patients before you prescribe them any treatment for osteoporosis. This is very, very important. We have seen numerous cases of patients with primary hyperparathyroidism, which was misdiagnosed, which was missed out, and these patients were put on teriparatide, or patients already having low turnover bone disease being put on bisphosphonates or such other medications, leading to something known as a subtrochanteric atypical femur fracture. So it's very, very important that you do baseline assessment. These are very simple tests. These do not cost too much, right? So they must be done in all patients before you begin any treatment. So these are all essential tests that you must do in all your patients. Apart from that, there are certain other clinical assessments which you need to do based on the clinical examination. So you need to see your patients, you need to do certain clinical things which you need to assess before you begin any form of treatment again. So first of all, you need to look for Cushing syndrome, both endogenous and iatrogenic Cushing's. Iatrogenic Cushing's, that is because of exogenous steroid use, is very, very common, especially patients. Some of these patients could be on alternative medications also. So some of these medications contain steroid or certain compounds which activate the steroid receptors. So it's very, very important to look for clinical signs of Cushing syndrome. If you're not experienced in looking for that, it's a good idea to consult your endocrinologist also before you feel that the patient could have Cushing syndrome. Cushing syndrome is a very important cause of osteoporosis. Again, we are talking about postmenopausal women, so you need to calculate the breast cancer risk. I'll tell you the reason why, and when we see the treatment, there are certain treatments where there is importance of breast cancer risk. So you need to talk to your patients about the family history of breast cancer, personal history of breast cancer, and again, there are certain other ways in which you can calculate the breast cancer risk also. There are certain medications which can contribute to osteoporosis. Glucocorticoids or steroids we already talked about. Then you have proton pump inhibitors, also contribute to osteoporosis. These are some common medications. There are other medications also commonly used by the patients which can contribute to osteoporosis. So again, you need to look at the medication history of the patient. For example, if the patient is diabetic, you have pioglitazone which can lead to osteoporosis. So these are all things you need to know. Again, diabetes mellitus history is very important. The reason is that sometimes diabetes, especially type 2 diabetes, the DEXA may not be very reliable. In fact, you might have a false normal DEXA values in diabetes mellitus. So again, you need to understand that these could be a potential problem, and hence, again, history of diabetes mellitus is very important. You need to see for clinical signs of thyrotoxicosis. We have seen numerous cases of clear thyrotoxicosis being missed out by doctors and just treating the osteoporosis. So it's very important again to look for clinical signs. I'm sure we all have seen patients with Graves' disease or other forms of thyrotoxicosis, which are not very difficult to recognize. But if you're again not sure, talk to your endocrinologist. Again, look at rheumatological conditions, rheumatoid arthritis and other things. This need to be looked at. Malabsorption is very, very important. We see numerous patients after bariatric surgery developing osteoporosis. Again, you need to look out for, you need to see whether your patient has chronic kidney disease, chronic liver disease. Some of your patients could be post-transplant also. So we have a separate lecture on our YouTube channel about post-transplant osteoporosis also. So these are some things you need to really look at and assess. Now, it's very, very important to look at the risk of vertebral fracture or to rule out vertebral fracture. So in which patients you should look for vertebral fracture assessment or doing a lateral spine X-ray. Now, certain, some of the recent machines, these, DEXA machines have something known as a VFA, which is called vertebral fracture assessment. Again, this is something for a separate lecture altogether, but if you have a patient where there is indication to look for vertebral fracture, you need to look for it. So what are the cases where you need to look for a vertebral fracture? Now, obviously, a patient complaining of back pain or radicular pain, you need to really look at this for sure. I'm sure you would have already done it, by the time we are doing this. But if a patient has more than 4 centimeter height loss, if the patient is shortening in height, patient having kyphosis, any patient on recent or long-term glucocorticoid therapy, all these patients you need to look at the risk of vertebral fracture. So you need to do a spine X-ray or you need to consider a VFA, vertebral fracture assessment, which if it's available in your DEXA machine. So it's again, so this is another essential test which must be done in all your patients before you consider treatment of patients with osteoporosis. Again, when we see the algorithm for management, you'll realize why this is so essential and so important. So these are the key first steps. And again, at the end of this first initial assessment, if you find that the patient has an endocrine condition, for example, if the patient has Cushing's syndrome or the patient has any rheumatological disorder, then you need to refer the patient to an endocrinologist or rheumatologist. Again, you will find some of these patients are also having primary hyperparathyroidism, right? Again, very, very important. In fact, primary hyperparathyroidism, according to a lot of endocrinologists, is the third most common endocrine condition after diabetes and hypothyroidism. So it's in fact a very, very common condition. So PHPT or primary hyperparathyroidism should not be missed out. Simple thing to do is calcium and PTH value. And if both your calcium and PTH value are high, it is primary hyperparathyroidism. And all these patients should be referred to an endocrinologist before any form of treatment is considered. You need to explain lifestyle measures to this patient. We'll discuss that, and vitamin D and calcium supplementation as needed according to the patient, right? In fact, a lot of Indian patients are severely vitamin D deficient, and sometimes even correcting the vitamin D improves the bone mineral density of the patient. So it's again something which you need to understand. And then finally, if you ruled out all these things, you ruled out secondary causes of osteoporosis, and you're dealing with a pure postmenopausal primary osteoporosis, then you move to the next step. That is the next step in the treatment of patients with primary osteoporosis. Now, we talked about lifestyle measures. So what kind of lifestyle measures should be encouraged for your patients? So you need to encourage them to exercise. Now, when we are talking about osteoporosis, the type of exercise that you really need to consider doing is weight bearing exercise. Of course, you need to see your patients and you need to see whether the patient can do a weight bearing exercise, but your isometric weight bearing exercises are what you need to really consider doing in your patients, and that's something you need to, again, you can discuss with your physiotherapist, but it's the best approach for your patient, making sure that the patient also doesn't get injured. Okay, you need to give adequate calcium and vitamin D to your patient. So you need to give 1200 milligram per day of calcium. We'll see what foods contain calcium also, so in the next slide, and at least 800 international units of vitamin D for adults with osteoporosis per day. So this is something which is, we are talking about patients with osteoporosis, and this is the recommendation. These are not normal patients, these are patients having osteoporosis, and these are the things you need to consider. If your patient is a smoker, you need to avoid smoking. Smoking does impact osteoporosis, and you need to ask your patient to reduce alcohol intake if they are doing so. So these are some food items which you can, which are sources of calcium. So about 200 ml of milk contains about 300 milligram of elemental calcium, and one bowl of yogurt has about 250 milligram of elemental calcium. Now remember, you need 1200 milligrams a day. So sometimes milk and curd are not enough to supplement. So for example, if a patient is having 1 glass of milk in a day, or about 200 ml, and about 1 bowl of dahi or chas or lassi, it is not enough, right? Because it will only provide about 600 milligram of calcium in a day, whereas your patient with osteoporosis would need 1200 milligrams. So some of these patients would require supplementation. Cheese contains about, again, 200 milligram. Paneer, about 100 gram of paneer contains about 100 milligram of calcium. Ice cream, beans contain a good amount of calcium also. Not good, but some amount of calcium. Green leafy vegetables, almonds contain a good amount of calcium. About 24 almonds contains about 100 grams of 70 milligram of calcium. And oranges contain calcium, right? Some of the orange juices in the West are actually infused with vitamin D and calcium, but that depends on your center. So maybe India, it's not that commonly done. So, you don't have, vitamin D put in orange juices, but again, this is, something which can be done in the future. So these are some of the sources of calcium and, good sources of calcium. So again, you need to encourage your patients to consume these food substances. Now let's look at the second step. And now we looked at the first step, that is the initial assessment. And now you're looking at the second step, which is the risk assessment of the patient. So when you have a patient with osteoporosis, now you already done the clinical assessment, the BMD DEXA, and you already done the patient's FREX score also. So after doing all this, you can categorize your patient into 3 categories. One is low to moderate risk, second is high risk, and third is very high risk patient. A low to moderate risk patient has all of the following. So the T score is is more than minus 2.5. So that means the patient's BMD is somewhere between -1 to -2.5. That's how you'll probably see. If the patient's 10-year FRAX score is less than 3%, remember when you calculate the FRAX score, you'll get the risk of hip fracture and the risk of major osteoporotic fracture. Why hip fracture is your sensitivity threshold for hip fracture is less, because you need to understand that hip fracture can lead to mortality. In fact, hip fracture is a very, very important cause of mortality in postmenopausal women. So again, hip fracture has to be taken very seriously. So if your 10-year FRAX risk score is less than 3%, you are fine. If your 10-year FRAX risk score for any major osteoporotic fracture is less than 20%, again, you're okay. So this would consider you in a low to moderate risk, or your patient low to moderate risk. What is high risk? High risk if any of these is true. So if the T score is not greater, again, I'm sure there's a mistake here, it is less than -2.5. If your 10-year FRAX score is, again, 10-year FRAX score is greater than 3%, and or your major osteoporotic fracture risk is more than 20%. So all of these puts you in a high risk category. Only thing is that there should not be a prior history of any fragility fracture. This is important because if you have a prior history of fragility fracture or multiple vertebral fractures, it puts you in a very high risk category, right? So what is high risk? High risk is if your BMD is a T score is less than -2.5, FRAX hip more than 3%, major osteotic fracture more than 20%, and there is with no prior history of fragility fracture. And then you have a very high risk category. Very high risk category is any patient with a prior history of fragility fracture or multiple vertebral fractures. That puts the patient into a very high risk category. So what is a fragility fracture? Now, if you fall from a standing height and fracture your bones, that is known as fragility fracture. Or you have spontaneous fracture without any kind of major injury, that is what is known as fragility fracture. So if you have a patient who has history of fragility fracture, so patient slipped in the bathroom and developed a fracture neck femur, or a patient was going on a bumpy road and developed vertebral fracture, or if you did a vertebral fracture assessment or an X-ray and found multiple vertebral fractures, all this puts the patient into a very high risk category. Now, we already done the risk assessment. Now, after you've done the risk assessment, you move to step 3. That is the first line management of these patients. Now, you can do 2 ways. There is the risk-based approach, and second is the bone turnover-based approach. This has been innovated by CMC Vellore. I really proud to say that CMC Vellore from India has been pioneering the bone turnover marker-based assessment. We'll discuss this also. Dr. Thomas Paul, we heard one of his lecture where he beautifully talked about bone turnover markers used as an initial assessment for using the treatment approach for patients with osteoporosis. Okay, so the first step is to do a risk-based versus a BTM based approach. So if you look, let's look at the risk based approach, right? So that is a standard approach. This is what has been suggested. This is based on the Endocrine Society guidelines and also AACE guidelines. So remember, this talk was supposed to be on mainly on guideline based treatment for osteoporosis. So this slide is basically based on the published clinical guidelines, recent clinical guidelines on the topic. Okay, so we have categorized the patients into 3 risk groups: low risk, high risk, and very high risk. Now, low risk patients require no specific treatment. All you need to do is keep assessing the patient every 2 to 4 years using your DEXA scan. But of course, your lifestyle measures and your vitamin D and your calcium intake has to be good. So all these things have to be taken into account. Some patients with moderate risk, you may consider giving them something like an alendronate, but generally, most of these patients, you can just mainly follow them up. Then you're looking at a high risk patient with a T-score greater than less than minus 2.5. These are the patients where you need to consider treatment, some form of therapy. So if again, in terms of therapy, there are 2 drugs which are considered first line therapy. So you have either denosumab, which may be considered as a first line therapy, or bisphosphonate, which is considered first line. Both, remember, a lot of people do not now understand this. Denosumab is not a second line therapy. Denosumab is now considered the first line therapy for treatment of osteoporosis. Only issue is cost. So you need to look at the cost of the patient. If the cost is not a factor, you need to consider giving denosumab as the first line therapy. Denosumab, if you see head-to-head clinical trials of denosumab versus bisphosphonate, denosumab has better results. It's also more convenient to administer. It is a subcutaneous injection which has to be given every 6 months. Only thing you have to be careful is that this patient has to keep taking the injection every 6 months, because if they don't, as soon as the injection effect goes away, the patient is again vulnerable to osteoporotic fracture. So that's the problem with denosumab. However, if cost is not a factor, cost is not an issue, denosumab should be the first line therapy in a high risk patient with osteoporosis. If cost is an issue, you can consider giving bisphosphonate. Now, to bisphosphonate, you have to consider either you have to give this patient alendronate, or which is oral, which is 70 milligram once a week, or you need to give this patient your patient injectable zoledronate, which is an annual once a year injection, right? So you have to consider one of these 2 therapies. Now, if there are any contraindications to first line therapy, then you can use second line therapy, and we'll discuss the second line therapy in a bit. And then if you have a patient with very high risk, for example, patient already having a fresh vertebral fracture, or a patient having multiple vertebral fractures, or a patient having a prior history or a recent history of a fracture, fragility fracture, all these conditions, you need to consider teriparatide as the first line therapy. Teriparatide is a bone anabolic agent. It builds the bone, so it's a more effective treatment. Problem with teriparatide is, again, it is costly. And the other second issue with teriparatide is that the teriparatide is a daily injection. I'll show you a turnaround to this also, but teriparatide is a daily injection, which makes it a little bit more, cumbersome for treatment. Okay, so in which cases teriparatide can be used as initial therapy. So patients with apologies for spelling, right? So teriparatide can be used as a first line therapy in any patients with severe or very high risk of osteoporosis. Any patient with T-score less than minus 3.5, you can consider giving teriparatide right away. A patient with T-score of less than minus 2.5 with fragility fracture, or if the patient has already received denosumab and bisphosphonate and then develops a fracture, again, you need to consider teriparatide. Okay, so teriparatide is typically given for 2 years. Now, of course, that cap has been removed recently, but at the same time, generally, most of the time in practice, we give it for 2 years, and after that, you need to switch to denosumab and bisphosphonate. Let's look at some second line therapy. So if the patient has some contraindications to first line therapy, you can consider putting the patient on a second line therapy. Now, when you talk about second line therapy for patients with osteoporosis, these are generally patients having some contraindications to first line therapy. What are the contraindications? So remember, chronic kidney disease used to be a contraindication, but remember, denosumab is safe in patients with CKD also. So again, that's not a contraindication. Mainly, generally, if you have a atypical femur fracture, or probably if you have some patient who is having osteonecrosis of jaw or something like that, some sort of such history, then you can probably consider using a second line therapy. But generally, most of the time, we don't require second line therapy. Now, second line therapy, if age is more than 60 years, you can consider giving raloxifene. And if the age is, remember, we are talking about post-menopausal women. And if age is less than 60 years, if the patient does not have any vasomotor symptoms, then you can give raloxifene. But if the patient has vasomotor symptoms and no contraindication to hormonal replacement therapy or menopause hormonal therapy, if the patient doesn't have a uterus, has undergone hysterectomy, then you need to give just estrogen alone, which is probably a very effective bone preserver. And if the patient has a uterus intact, then you need to give estrogen with progesterone. or you can give Tibolon. These are all second line potential therapies for patients with osteoporosis. So again, consider first line therapy, but if the patient has some reason for not taking first line therapy, you can consider second line therapy. Now, there is an innovative approach for doing this using bone turnover markers. Bone turnover markers are basically blood tests. We'll see what they are. So there are two major bone turnover markers that we do in India. One is known as C-telopeptide, which is otherwise known as beta cross-Lebs. It's a marker of bone resorption. And the second commonly available marker in India is P1NP, which is commonly a bone formation marker. So these are two markers which are commonly available in clinical practice in India, and these can be used judiciously for using as a form of treatment. Now, Indians tend to have a different value for bone turnover markers, or our Indian values need to be considered when you're interpreting these results. In India, the bone turnover marker is about 20-30% more than Caucasians. We tend to have, more is not good actually. So in a sense, right? So that's a problem. So here is a paper where they looked at from India, where they looked at the normal values of bone turnover marker in India. So you can take a screenshot of this. You can use this in clinical practice when you are interpreting these results. So again, you have the data for postmenopausal women over here. So you have the mean plus minus 2 standard deviation and the reference range for CTX and P1NP. CTX and P1NP, or C-telopeptide and P1NP, are the ones that we use most commonly in clinical practice. So if you have values outside of this, you should consider as a thing, right? How do you test for bone turnover markers? Like I said, bone turnover markers are now easily available in a lot of labs. They need to be done generally in the morning, fasting between 8 to 10 a.m. And if it's a female, of course, we are doing with postmenopausal women, but if it's a premenopausal woman who is menstruating, you need to do it in the follicular phase of the cycle. Now, how do you do the assessment of treatment based on bone turnover markers? Now, if you have both P1NP and CTX are high, that means that the bone cycle is very fast, right? So you have high turnover bone disease. So this is suggestive of high turnover of the bone. And when you have a high turnover, you need to give a drug which reduces the turnover. The best drug to use are anti-resorptive agents. Remember, anti-resorptive agents are denosumab and bisphosphonate. So if you have a patient with both high P1NP and CTX, then you need to consider an agent which is anti-resorptive, like something like a denosumab or a bisphosphonate. So that is how you do it. Now, if the P1NP and CTX are low, that means both the turnover markers are low. This is suggestive of a low turnover bone disease, in which case it is always better to use anabolic therapy, right? It's very useful to do that. And again, here, this is where you use a teriparatide, which is an anabolic agent. And if the P1NP is low and CTX is high, that means the bone breakdown is high, but bone formation is less. Again, this suggests more destruction than formation. Again, in this case also, it is better to use an anabolic therapy first, that is, use teriparatide first, and then you can switch to anti-resorptive therapy. So again, this is a case where you use teriparatide followed by denosumab or bisphosphonate, right? So this is how you can consider treating this patient based on the bone turnover marker based assessment. Like I said, this is a very innovative approach. I've seen papers by CMC Vellore on this, a little bit by PGI Chandigarh also. So it's a very good idea. Again, an Indian innovation where it's something which is very useful. Okay. So like I said, these BTM based assessments are from CMC Vellore, credit to Dr. Thomas Paul. And there's another paper where they looked at teriparatide can be given every 4 days in a week instead of taking it daily. Again, there's a paper from PGI Chandigarh. If you check the Endocrinology India YouTube channel, we have a video on teriparatide where we discuss in detail about the giving teriparatide once every 4 days. This is a paper from PGI by Dr. Sanjay Parara. So you can check out this paper. You can check out the video also to get more details on this. Right. So we did the risk assessment. We started the first line therapy. Now let's follow up these patients. How do you follow up these patients? If you're doing a bone turnover marker, you need to do every 3 months. Again, this is optional. It's not necessary that you do bone turnover marker. But if you have the patient who can afford and you can follow up this patient, you can do a BTM every 3 months. You can do DEXA every 2 years. Remember, the DEXA is generally repeated at 2 years, generally with the same machine and with the same operator. I'm going to discuss this point in a little bit of more detail. Now, when we talk about bone turnover marker, of course, remember this is generally optional. But if you are using a BTM, generally you expect that the bone breakdown marker, which is the CTX, generally normalizes in 3 to 6 months after starting treatment. And if the bone formation marker is used like P1NP, generally it normalizes at 6 to 9 months after starting treatment, right? So again, you are using CTX and P1NP, and this should come into normal range. Remember, bone formation marker is P1NP and the bone breakdown marker is CTX, right? You can use both. You can use one depending on your clinical practice, and from your understanding of what we discussed earlier. Okay. Well, when do you do BMD? So BMD DEXA is repeated after 2 years after starting treatment. If the BMD is stable or you improvement in the BMD, then you can monitor less frequently, but you can consider every 2 years. Generally, repeating at 1 year is not such a good idea, but then every 2 years you must consider repeating. Right now, when is a bone mineral density considered, change in bone mineral density considered significant? This is a very, very useful thing, right? So let me explain this concept to you. So what happens is that when the bone mineral density is measured, if you even have the same machine and you have the same technician doing the test, there could still be error. This is called precision error, and this precision error is generally, though very small, remember the bone mineral density values are also very small, so sometimes the precision error itself can lead to errors in interpretation. So you need to see what is known as least significant change, LSC, right? And least significant change is defined, is calculated as 2.77 multiplied by the precision error for BMD by a particular technologist or by a particular a technician, right? So precision error, there is a ISCD calculator. So Indian Society of Clinical Densitometry has a calculator for calculating precision error. I'll discuss this in a minute. And this can be done by the technologist himself. We can in fact feed this into the software. Some of these newer machines have this software available, so you can feed the data into the software. It will give you the LSC and it will also give you the significant change in the value of the BMD. Now, so machine can also give LSC, but they may be, generally less than an error, but sometimes technologists may have more errors. So you need to again calculate, and the value which is given, which you get, is the least significant change is in gram per centimeter square. So that's the value you get, right? Let's discuss this in more detail, more on least significant change. So first of all, what the technologist has to do, has to go online. There is an ISCD calculator. So what he or she has to do is, repeat the scan at the same time in the same patient, and at least 2 or more scans, right? And do 2 or more scans, he or she needs to enter the value. So remember, the positioning of the patient and a lot of the readings taken by the machine, because depending on the position and all the other things, can be erroneous. So even in the same patient repeated twice, sometimes you can have a difference in value, right? So you need to take different places where you check the value, right? Your hip and your vertebra, and then you need, the operator needs to put this value. Generally need about 15 to 30 patient data, at least 2 scans in each of them, and then you need to put this data. And when you put this data on the calculator, it will give you the ISCD calculator will give you what is known as the precision error. And when you get the precision error for the technologist, then you do 2.77 into precision error, which will give you the least significant change. Now you have a patient, you have 2 DEXA reading of the patient. Let's say we have a Mrs. X, in which you have taken the value in 2021 and now 2023, right? So you need to first see the bone mineral density value, not the T-score, okay? Remember, you don't see the T-score, you see the bone mineral density value. So you can flip the pages and you can see the bone mineral density value. The value will be in gram per centimeter square. Generally, we do not check the radius, so you check it at your hip and your vertebra. If you're using a GE machine, then generally it's better to check at the femoral neck. Right, so this is the places where you check for the least significant change. So you take the reading, previous reading and current reading. You see the change in the reading, and this change in the reading, let's say change in the reading is, let's say 0.05, right? So this value has to be more than the least significant change, right? So if the least significant change is, let's say 0.04 and our change is 0.05, that means the change is more than the least significant change. That means the change is statistically significant, right? On the other hand, let's say our change was 0.03 and the least significant change is 0.04. That means there is a change. The change is less than the least significant change. That means the change is not significant and can be ignored. Okay, we can say that the BMD value is more or less the same, right? So this is how you generally calculate the least significant change, right? Now, if you have a decline in BMD, right, in a patient on treatment, so you have a patient who is on treatment and the previous BMD, the current BMD value is less than the previous BMD value, and it is more than the least significant change. So let's say the difference is 0.05, right? So you have reduced bone mineral density by 0.05, let's say at the femoral neck. The least significant change was 0.04. That means there is a significant decline. Then what do you do, right? So what do you do in this situation? So first step is again to check whether the patient is taking calcium, vitamin D, check the adherence to whatever treatment you're giving. So you're giving denosumab or you're giving bisphosphonate, whatever. See whether the patient is adherent to treatment. If the patient is taking an oral agent like alendronate, you need to check the absorption, whether it's properly being absorbed. Once you've done all these basic things, then you can move at second step. Second step, you look at the significance of the change, right? So if the decline is less than 5%, probably you can consider the same drug. You looked at all the other factors, same drug, and repeat the DEXA after 2 years. But if the decline is more than 5%, then you need to switch to alternate therapy, right? So you can change the therapy if the significance decline is more than 5%, right? So what therapy you can change, again, that would depend on what initial therapy you're given, right? Third step is if the patient, there are fractures while on treatment. So if the patient is already on anti-resorptive therapy like denosumab or bisphosphonate and the patient develops a fracture, then you need to consider switching to teriparatide, right? So teriparatide is a bone anabolic agent. Of course, you need to understand that teriparatide is going to be less effective when given after giving anti-resorptive therapy. However, if the patient has fracture, it is always a good idea to switch to teriparatide rather than continuing the patient on anti-resorptive treatment, right? So that's the lecture today, right? So just to summarize 3 take-home messages, remember, very importantly, it's always important to do a proper baseline assessment in all patients before starting therapy. At least a calcium, vitamin D, alkaline phosphatase, these tests you must do in all your patient. Also look at the patient clinically, look at any secondary cause for osteoporosis and rule it out, and consider sending to a specialist like an endocrinologist or a rheumatologist depending on the condition which you are dealing with. Second important step is denosumab or bisphosphonate. Both are first-line treatment for high-risk women with osteoporosis. High-risk women are those with a T-score less than -2.5. And teriparatide can be considered in very high-risk women who already have multiple vertebral fractures or a fresh recent fracture. Third step, very important, third important message is to reassess the DEXA scan every 2 years. And if there is decline in BMD beyond the least significant change, more than 5%, you can consider changing the therapy for the patient, right, after looking at the basic parameters. So thank you for a patient listening. Thank you.